طيب, we return to the first speakers. دكتورة حنان صادق الحكيمي, Malignant glaucoma case presentation, supervised by دكتور علي الشيخان. معلش, دكتورة حنان.
Hello, yeah, can you hear me?
Yes, start sharing
Okay.
your screen.
Okay. Can you all see my screen?
Yes, nice.
Thank you,
Okay,
yes.
let's just... Okay, so should I start?
Yes.
Okay. Thank you everyone for this great opportunity. My name is Hanan Sadiq Al-Hakimi, second year ophthalmology resident from Yemen. Today I'll present to you malignant glaucoma case presentation under the supervision of Dr. Mohammed Al-Hamiri. Those are my outlines that I'm going to discuss during my presentation. So we have a 63-year-old female patient referred to us as a glaucoma case. She was presented complaining of headache, eye pain, and decreased vision. She had a past history of bilateral cataract surgery. She was on maximum anti-glaucoma medication. There was no other medical history. Her clinical examination showed the visual acuity to be 20/200 with tunnel vision in the right eye. The best for corrected visual acuity was 20/30, while in the left eye there was no light perception. The IOP was 28 millimeter mercury in the right and 40 millimeter mercury in the left. Her slit lamp examination showed clear cornea bilaterally. The AC depth was grade 2 according to Fenher classification. The pupil was round, regular, reacting to the light, or in the right eye, while in the left eye it was mid-dilated, not reacting to the light. The iris was normal bilaterally with pseudophakia bilateral. Her gonioscopy lens examination showed closed interior angle, while the fundus examination showed the CD ratio to be 0.8 in the right eye, while there was glaucomatous optic atrophy in the left. So the immediate decision was to do an immediate bilateral BI, and then she was scheduled for trabeculectomy for her right seeing eye. Her trabeculectomy passed smoothly. This is a video of the trabeculectomy. We did a superior rectus holding. Then we are doing a barretomy. Here we are creating the scleral flap, and we do a pre-placed suture to help us and to do a better prognosis. Here we are entering the AC. You see the aqueous coming out, and then we are doing the surgical peripheral iridectomy. Then we tie the scleral flap, not too tight, not too loose. Then we close the conjunctiva. We will finish the operation by forming the AC and do thermal hydration. However, unfortunately, in the first day post-operation, the patient presented with shallow AC, tense eye digitally, the IOP was 60 millimeter mercury, and the visual acuity dropped to hand movement. So we start to think what may happen. We have a high IOP post-trabeculectomy surgery. So is it pupillated block? This was excluded by the patent PI. Is it suprachoroidal hemorrhage? We sent the patient to do an ultrasound. The ultrasound result was normal. So we were left with diagnosis of exclusion, which is malignant glaucoma. We immediately started the medical management of malignant glaucoma, which includes cycloplegic, aqueous suppressant agent, osmotic agent, and steroid. However, unfortunately, 2 days after medical treatment, there was no improvement. The AC was still shallow. The patient still complained of headache and ocular pain. The IOP was still 60 millimeter mercury. So the decision was to refer the patient to a vitreoretinal surgeon to do barosplantar core vitrectomy. After the barosplantar core vitrectomy, thank God the ocular pain and headache resolved. The IOP dropped to 12 millimeter mercury and the AC was formed. There was a slight corneal haziness. However, for 4 days after the vitrectomy, while she was taking her medication, the AC became shallow again. The IOP raised to 40 millimeter mercury again. So the decision was to do another vitrectomy. However, this time was an interior vitrectomy through the patent PI and posterior capsulotomy. After the operation, thank God, the AC was formed again. The IOP was 22, dropping to 12 millimeter mercury by massage. There was mild to moderate corneal haziness. This is a video of the anterior vitrectomy operation. Here we are fixing the eye. Then we will do the barretomy. We will raise the scleral flap that we create in the trabeculectomy operation. We will do formation of the AC. We will enter by the vitrectome through the patent PI and posterior capsulotomy to the vitreous. As you can see here, a gush of the vitreous. We are doing interior vitrectomy and interior hyaloid removal. Then we will just close the scleral flap and the conjunctiva, and we will finish the operation. There was a slight corneal dizziness, as I said before. When it subsided and we do fundus examination, there was a slight macular hemorrhage. During 2 months following up of the patient, the visual acuity improved to the IOP was between 12 to 14 millimeter mercury in all of her visit with no anti-glaucoma medication. The bleb was firm, the AZ was firm, the cornea was clear, the BI was patent, and the macular hemorrhage improved. This is some picture of the patient after the first vitrectomy and post 2 months following up. So what is malignant glaucoma? It was first coined by Von Grave in 1869. It is an aggressive form of post-operative glaucoma resistant to treatment, resultant in blindness. It is also known as ciliary block glaucoma, acute misdirection syndrome, dark lens block glaucoma. It is reported in 0.4 to 6% of incisional surgeries for patient of primary angle closure glaucoma. 2 to 4% has history of acute or chronic angle closure glaucoma and undergone filtration surgery. It is more common in women and white people. It is rarely reported in non-surgical or spontaneous situations. Classification, as all of us know, it is either classic, non-phakic, or other glaucoma syndromes associated, like post-laser treatment, using of miotics, or post-trabeculectomy bleb needling. Pathophysiology, there are multiple theories regarding this. We can conclude that it is a multifactorial condition resulting in alteration in the anatomic relationship of the lens, ciliary body, interior hyaloid face, and the vitreous, resulting in a viscous cycle. Clinical features, maybe there's pain, inflammation, corneal edema. However, malignant glaucoma is diagnosed when there is increased IOP, shallow AC, and normal hemorrhage or pupillary block, because the management is different. Principle of management: after you make an accurate diagnosis and you exclude or other differentials, you proceed with the medical therapy, which is cycloplegic, acute-suppressant agent, osmotic agent, steroid. If this fails and the patient is pseudophakic, you will proceed to the laser therapy. If it is failed, you will go to the surgical therapy, which is vitrectomy. However, if the patient is phakic, you will directly proceed after the medical to the surgical, which is cataract extraction with
دكتورة حنان. دكتورة حنان.
Yeah.
Again.
Can you hear me?
Yes, some interrupted.
Yes, we had some connection problem.
Again, last slide. دكتورة حنان, there is some technical problem. دكتورة حنان.
Dr. Hanan lost the connection.
Yes, he will come. Yes. Unmute, دكتورة حنان.
You are muted.
دكتورة حنان, unmute.
دكتور طارق، أنت ممكن as a host to mute or unmute presenters.
Okay. دكتورة حنان, also some technical problem.
Presenter 3 is raising hand.
Can you hear me now, Dr. Tariq?
Yes, we are hear you.
Okay, so I'll
again,
just share my
slide.
screen.
Yes.
Sorry, I'm just going to share my screen. Sorry, the internet is not strong. So can you see my screen?
Yes.
Yes.
Okay. We were saying that you have to know that any patient with malignant glaucoma in one eye have an increased risk factor of having malignant glaucoma in the other eye after any surgical intervention. So prophylactic measures should be taken. Prophylactic BI, avoid and stop any miotic drops. You have to prolong the use of atropine after trabeculectomy surgery, and you have to consider vitrectomy. So in conclusion, So in conclusion, malignant glaucoma is a therapeutic challenge. All eyes with primary angle closure glaucoma should be closely followed up after operation. If a patient develops malignant glaucoma in one eye, prophylactic measures should be taken in the other eye. Take-home messages: you should put malignant glaucoma in your differential diagnosis after excluding or other differentials. You have to tell the patient that malignant glaucoma doesn't indicate a neoplastic process, and malignant glaucoma is a nightmare. However, it is treatable. You have to start management of malignant glaucoma as soon as you suspected. Those are my references. Thank you.
Thank you, Dr. Hanan, for this nice presentation. Dr. Ali, start
Yes.
discussion with 3 minutes.
3 minutes.
Okay.
Yeah. Can you stop sharing, Dr. Hanan?
Differences ما شفت.
Yeah. Thank you, Dr. Hanan, for this nice presentation. Are you hearing me, Dr. Hanan? Disconnected, I think, yes, again.
Hello.
Dr.
I'm sorry, the internet
yeah.
is the worst. I'm really sorry
Yeah.
for
Are you
the
hearing
bad
well?
connection.
Yeah. Now I go to thesis for that for the slide, and after that ask you some question. First of all, this is here we started with anti-glaucoma medication. You mentioned for anti-glaucoma medication for generic name. This is very important always to mention for any scientific name in any slide, not to mention for any generic name. When you mention for the gonio, you mentioned this is with the gonio is angle closure. With gonio should mention this is how much the angle is closure 0 and what is the classification, Schaefer or other.
Wait, I said, sorry, doctor, I said it has been her classification grade 2.
Yeah, but this is for the second. After that, the next line you mentioned gonioscopy. Gonioscopy, you mentioned this is a closed angle.
Yeah.
Yeah. Yeah. This is
Yeah,
with gonioscopy.
yeah.
You cannot mention that. You should mention this is how much the grade for the
Yeah,
angle
the
closure.
Schaeffers, yeah.
Yeah,
Sorry,
should Schaeffers or other, but for that, you should be mentioned about that. When the patient come with this high IOP from the first, why the IOP decreased on BI?
Because most probably she was having primary angle closure glaucoma.
Yeah, but the primary angle closure glaucoma and pseudophakic eye. Why this is angle closure? If this is the anterior chamber is homogeneous shallow or not, or there is iris bombae.
No, there is no iris bombae. It was homogeneous shallowing.
Homogeneous shallow and pseudophakic eye, then should not go direct thinking another thing is not as normal. This one point.
Okay.
The second, when the patient come to this again with high IOP, you plan this is after trabeculectomy, you thinking about malignant glaucoma, this is direct. Why this when the patient is not response to the medication, not follow the stepwise management? Why you said the patient?
We didn't go to the laser therapy because of two things. The economic state of the patient, and the second thing, because according to the surgeon expertise and many studies that was done, the prognosis and outcomes of the surgical management is better than the laser management, and the patient only has one seeing eye.
Which laser therapy you mentioned?
The what?
You said we didn't go to the laser. Which laser?
The ag laser therapy. The argon. The argon therapy. The argon laser therapy.
Argon for what?
I'm sorry, the YAG. For to do zonulolysis and capsulotomy.
Yeah, zonulolysis. For that, this is explain why the patient benefit from the second vitrectomy, not from the first vitrectomy. When you go for the next, you make an iridozonulohyaleotomy. On this stage, you follow the stepwise. For that, your patient benefit from the treatment. For that, you lost the patient one step by going directly to the vitrectomy, not to follow the stepwise. This is very important point. Should be concentrate about this in your conclusion, because I think that your conclusion was follow the we should learn from our mistake, For that, I think is from this case, the most important point is to learn to go stepwise by the management. For that is very important in this case. If we concentrate to go stepwise by the management, we will save the patient one surgery or more. This is here, that's the point. Okay?
Okay.
Thank you.
Thank you.
Thank you,
Thank you
Dr.
very
Ali.
much.
Thank you, Dr. Ali. Thank you, Dr. Hanan. Now we can
You're
go
welcome.
into second speakers. Welcome also Dr. Muhammad Al-Himari. Second speaker, Dr. Qais Muhaysin. He speak about PreserFlo micro shunt implant, a case study in secondary glaucoma post-penetrating keratoplasty. Start, Doctor, for sharing your slide.
Okay, 1 second, please.
Okay, take your time.
Okay, can you see my screen?
Yes, start.
So I would like just to mention briefly, because I know we don't have time, I would like to introduce myself. My name is Qais Muhaysin. I live in Poland. I'm originally from Syria. And I would like to just say a few things about the Arab contribution and legacy to ophthalmology, and mention the famous surgeon Ibn Sina, which was one of the first who diagnosed the signs of glaucoma. Beginning with my presentation, I would just like to say about the mixed classification, which divides the anti-glaucoma surgeries. And our device, PreserFlo microshunt, is in the group of the subconjunctival shunts. The device is 8.5 millimeters long. It's implanted subconjunctively, ab externo. It's bypassed the physiological outflow, and the safety and efficiency is confirmed in numerous clinical studies. It drains the aqueous humors from the anterior chamber to the filtration bleb under the Tenon's capsule. It's important to use mitomycin C, which prevents excessive scarring of the filtration bleb. It improves the long-term outcomes, and it has like more effective effects on lowering the IOP. So on the illustration, I wanted to just show where the implant is located. We need to just consider that it utilizes the same outflow as trabeculectomy. So it's similar to it. It drains the aqueous humor from the anterior chamber to a subconjunctival space under the Tenon's capsule. This allows bypassing the high resistance that occurs in the other parts of the normal aqueous outflow pathway, for example, in the trabecular meshwork. So the device is 8.5 millimeters long. It has two ends. The distal ends drains from the aqueous humor. It's 70 micrometers. And the substance, which is the CIBS, of which is made, prevents of clotting. Not always, but it prevents of clotting the material inside of the device. So I wanted to compare it to the trabeculectomy. Our device has a shorter procedure time, higher safety profile, but on the other hand, it's a new technique, requires training, and it's less effective with the high pressure. Trabeculectomy has it has more effect on lowering IOP, but we have more post-operative complications, and it's more frequent for further surgical intervention in some cases. So the indications to implantation are patients with primary open glaucoma, pseudoexfoliation glaucoma, pigmentary glaucoma. It's important to mention that it's possible to simultaneously do a cataract phacoemulsification surgery. The contraindications to the surgery are close angle glaucoma, active iris neovascularization, present scars in the conjunctiva, any active inflammation, traumatic glaucoma, vitreous body in the anterior chamber, or presence of an anterior chamber intraocular lens. There is a meta-analysis which was done by Dr. Papilledema. This meta-analyze joined 14 studies, and the average post-operative IOP based on these studies is 11.7. So it's lowering, it has like significantly reduced IOP from 22 till 11. So totally of 1,200 patients, more than 1,200 patients had the surgery, and the average IOP was 22, and 3 years post-operatively, it was around 11. So we have like 66% patients did not require any glaucoma medications after the surgery. So maybe not this slide, yes. I would like to say now about my case. The case involves a 73-year-old female patient who underwent penetrating keratoplasty 2 years ago. The surgery was necessitated by persistent bullous keratopathy, which developed secondary to cataract phacoemulsification. Despite receiving comprehensive local treatment with 4 different groups of anti-glaucoma medications, the patient unfortunately developed secondary glaucoma. The condition was further complicated by advanced optic neuropathy. Just not this pen. And I would just like to discuss PK and post-operative glaucoma as well. Penetrating keratoplasty elevates glaucoma risk due to mechanism like peripheral anterior syncytia, trabecular meshwork inflammation, steroid-induced ocular hypertension. It's important to early detect and manage IOP because it's crucial for preventing graft survival and preventing permanent visual loss. IOP elevation can result from factors like retained viscoelastic, pupillary block, steroid-induced ocular hypertension, and so on. So this is the photo of the anterior segment after the surgery. Here we can see in the anterior OCT that the implant is located in a safe distance from the corneal endothelium. And why I'm like emphasizing that, there are some studies which showed that when the implant is too close to the endothelium, you can have endothelial loss. And in our case, where we have patient after penetrating keratoplasty, it's crucial and it's very important to for the graft to survive. Here we have some map diameters after the surgery, pachymetry map and epithelial map. We didn't see any big refractory changes after the implantation of the device. So our post-operative outcomes was the corneal transplant was unaffected. There were no significant refractory changes. The visual acuity was stable, which was 0.4, and the reduction of IOP was 40%. So
conclusion, Doctor.
Our conclusion, the effectiveness of PreserFlo microshunt. The case study demonstrated that successful control of secondary glaucoma after PK using PreserFlo microshunt showed a significant reduction of IOP in favorable patient outcomes. PreserFlo microshunt offers a less invasive alternative to traditional surgery like trabeculectomy, provides patients with a quicker recovery time and avoids common post-operative complications such as hypothony, which is not so rare in trabeculectomy. Future treatment option, it shows a promise future treatment, which I would like just to mention that it's not, it's like a little bit of off-label because there is no indication that this surgery can be done post-PK. But considering our patients which had a deep anterior chamber, like anatomically was suitable for the device to be implanted. So it's a potential alternative to conventional surgeries.
Dr. Qais is
Yes.
Thank you, Dr. Qais. Thank you, Dr. Qais, for this nice presentation. My question is, since the microshunt is the or PreserFlo microshunt, it's like a tube. What are the main complications of this microshunt?
The main complication is around 11% of the implanted devices have some occlusion. So we implant the device, and after 3-4 months, we see the patient, and primary his IOP post-surgically was, for example, 18 millimeters and 18 millimeters of pressure. And after 3 months, due to the occlusion, we have 30. So we have like a surgery when we put a special suture, which is like 0.9 nylon, and we try to make the outflow.
Any side threatening complications like shunt exposure or over drainage of the shunt.
In our hospital, we implanted like more than 200 of it. We didn't notice any side threatening complications. Even we didn't observe any hyphema, which is potentially a complication. We didn't observe that. We didn't observe any bigger.
Do you know what are the precautions taken to prevent these complications if happened? Because there are cases recorded that these complications is happened like shunt exposure or over drainage. In case of over drainage, do you know what precaution you can do to prevent over drainage of this micro shunt?
I think you can put like a suture in it to make it less the lumen is narrower. The lumen is more narrow after if we put a special suture in it.
Yeah. Thank you, Dr. Qais. It's a very nice presentation. Thank you very much.
It's a pleasure to be with you and with the Arab doctors and professors. It's a big pleasure.
Thank you, Dr. Mohammed Al-Himari. Thank you, Dr. Qais. Now we can move to third speakers. Dr. Marwa. Stop sharing, Dr. Qais.
Okay. I'll just try to do it. Stop sharing.
Dr. Marwa.
Good evening, everyone.
Yes, supervised by Prof. Dr. Suzanne. The case report of Crouzon syndrome.
Okay. I wanted to share my screen just 1 second.
Okay, done.
Just 1 second, please.
Okay, take your time. Do you know how can you share presentation or not? Yes.
Is it visible?
Yes, now it's clear.
Okay. Good evening, everyone. At the beginning, I wanted to thank all the attendees of this meeting. I am Marwa Ahmed Abdelail, Assistant Lecturer at Ophthalmology Department, Kasr Aini Cairo University. Today, I wanted to share a presentation, a case of 3-year-old boy presented to casualty complaining of the frequent bulging of the eye. The condition started since birth and that increased during crying and straining. By history taking, the baby was full-term baby, no history of NICU admission, and history of congenital heart disease. He had an open heart surgery at the age of 1 year, and also he had an abdominal hernia that operated at the age of 2 years. By examination of the patient, he has bilateral axial proptosis, alternating XT, bilateral clear cornea and anterior segment, and also bilateral fundi, and cup disc ratio was about 0.2. After revising investigation of the patient, the labs was normal CBC, and also abdominal ultrasound was normal. There was an echocardiogram before surgery and post-surgery. Before surgery, he has a patent ductus arteriosus, and post-surgery, he has closed duct and moderate pulmonary hypertension. After revising MRI of the patient, it was normal. CT brain was normal, apart from apparent proptosis and positional plagiocefali. After asking for genetic consultation for this baby and searching for a hereditary disease, the patient was diagnosed as a Crouzon syndrome. Crouzon syndrome is an autosomal dominant genetic disorder caused by mutation in the fibroblast growth factor receptor 2. It's located on chromosome 10, and it's known as a branchial arch syndrome. It affects the first branchial arch, which is a precursor of maxilla and mandible. It's characterized by premature fusion of certain skull bones. It's called craniosynostosis. Early fusion of these bones that prevent skull from growing normally, and that may affect the shape of the head and face. Its Crouzon syndrome is it's seen about 16 per million newborn. It is the most common craniosynostosis syndrome. Signs and symptoms include craniosynostosis, which is premature closure of some or all sutures that lead to abnormal head shape, exophthalmos due to shallow eye socket and shallow orbit, and early fusion of surrounding bones. It's also characterized by hypertelorism, beak-like nose, strabismus, hypoplastic maxilla, and mandibular prognathism, and protruding chin. 30% of the patients developed hydrocephalus, sensorineural hearing loss, and hypodontia, and severity vary among these people, but the intelligence was normal. Ocular features include proptosis that occur due to shallow orbits, extrovia, exposure keratopathy, hypertelorism. Optic atrophy occurs secondary to chronic papilledema, and also may lead to amblyopia, nystagmus, congenital glaucoma due to closed angle. About speech and language, language skills are usually within normal, but there are some primary struggles that involve articulation and voice and social communication. Communication struggles are that occurs due to involvement of the palate and hearing loss. For diagnosis of these patients or this syndrome, the diagnosis usually occurs at birth by assessing the physical appearance of the baby, and MRI scan, genetic testing, and CT help in confirmation of the diagnosis. Treatment follows by surgery. Surgery is done to prevent the closure of the sutures of the skull and prevent damage of the brain development. Without surgery, blindness and intellectual disorders may occur. Once the patient is treated, he has a normal lifespan. Other craniosynostosis types include Apert syndrome. It's characterized by abnormal skull shape, small upper jaw, fusion of fingers and toes. Also, Kiefer syndrome, there's abnormality in the skull, hand and feet, wide set and bulging eye, underdeveloped upper jaw and big nose. Caesar-Schuster syndrome, characterized by short or broad head, and the eyes may be spaced wide apart, hypertelorism, and have a palpebral ptosis due to droopy eyelids. Fingers may be abnormally short and wide. There's a reference of my presentation, and finally, in conclusion, in any patient diagnosed in the Crouzon syndrome, we should get concerned about the high IOP and angle closure glaucoma, and to prevent optic atrophy also from chronic papilledema, to preserve the vision of the baby and prevent his blindness, in order to live his life normally. So, thank you.
Thank you, Doctora, for this exact time. Dr. Suzanne, discuss it.
Thank you, Dr. Marwa, for this interesting case. Dr. Marwa, this baby, he is unlucky. He had 2 surgeries before. Did they diagnose him Crouzon, or what? Only when he came to you, you diagnosed him as a Crouzon?
When the baby came to us, we referred him to the pediatric consultant, and he did the genetic counseling and did a hereditary tests more and more, and finally the pediatric surgeon, pediatric surgeon who got the result that the baby was like Crouzon syndrome. It's not our ophthalmology department.
Yeah. So he had delayed presentation, the delayed diagnosis. هذا اللي بالconclusion أو بالmessage اللي أنت البيرل اللي قلتي لنا إياه إنه we should diagnose early so that he should be treated before any complication will happen.
Yes.
So he was unlucky in he had 2 surgeries and he was missed for this diagnosis. Anyhow, what about, you said CD was 0.2. I didn't notice the visual acuity. Did you mention anything about the visual acuity?
About vision of this patient was 3 years
What was his
3 years
visual
old.
acuity? Yes,
His
his
age
vision.
was 3. He was uncooperative with examination and visual acuity. He can fix and follow, and he can get some things about about text meter. He can see that. He can notice his mother, and he is lucky that his optic nerve was a normal, and even by investigations, it was a normal nerve. There is no atrophy. There is ganglion cell fibers not affected. He has also no cupping. He was lucky in this, and he has a preserved vision still. Vision assessed by investigations,
Yes, he was
ERV,
lucky in that.
and VEB, but not by charting.
Okay, yeah, the optic nerve function was more or less normal. So he was lucky
with
to
that.
present
Yes.
to you. Thank you, Dr. Marwa.
Thank you for.
Thank you, Professor Dan. Thank you, Dr. Marwa. Now the fourth speakers, stop sharing, yes. Dr. Ayan. Yes, Dr. Ayan, supervised by Dr. Iyad Habil, bilateral papilloedema case report.
Hi, can you see me my presentations?
Yes.
Yes.
Yes, but for screen your presentation.
Just a minute. Sorry,
Yes.
just a minute.
Yes, yes. Start, Dr. Ayan.
Okay. Good evening to everyone. First of all, I would like to thank to all the panelists, to our board members, to professors, and I'm very happy for this great opportunity. My name is Ayan Galbinur, and I am here for presenting a case report about bilateral papilledema. Sorry, just a minute, but I can't. It's good. Okay. I have no any financial interest. So about okay, today I'm going to talk about introduction, aim, case presentation, discussion, and management of the goals. Just a minute, I have a problem in this.
No, it's okay.
I don't know why.
It's okay. Move slide.
Okay. Can I start again?
Yes.
Okay. Can you see me now?
Yes,
Yes,
yes.
yes.
Okay. So today I'm going to talk about the patient with papilledema, diagnostic evaluation, management strategies, and long-term prognosis.
It's nice. Start. Go. In mute.
You muted yourself, Ayan.
Okay.
Now it's okay. We hear you.
Just a minute. Okay, so I'm going to talk about emphasize the importance of early diagnosis of papilledema, identification of etiology, prompt intervention for better patient outcomes. So my case report about the 32 years old young obese lady. She presented to our clinic with complaining of both eyes, sudden decrease in the central and peripheral vision. She had complete loss of vision for a few seconds, severe intractable headache since 3 months. So on examination, best corrected visual acuity on right eye was 20 to 28, on left eye was 20 to 25. No relative afferent pupillary defect we found. Anterior segment was normal, and examination of oculomotor nerves was normal. Intraocular pressure also was normal. On fundus photo of both eyes at initial examination demonstrated moderate bilateral optic disc edema. On OCT, optical coherence tomography showed that the thickness of the retinal nerve fiber layer was 267 micrometer in the right eye and 460 micrometer in the left eye. Our plan was to exclude space-occupied lesions. The patients underwent magnetic resonance imaging of the brain, which didn't reveal any pathology. The patient was then referred to a neurologist for lumbar puncture, which included determination of cerebrospinal fluid pressure and this cerebrospinal fluid composition was normal, and the vision immediately, we saw the improvement in the vision after lumbar puncture. So the plan for her was started acetazolamide for 250 milligram 3 times a day initially for 3 months. Then for 2 months, 500 milligram for 2 times. Then for 1 month, 500 milligram for 1 time. And after examination 6 months, the papilledema had improved significantly, but not disappeared completely. Best corrected visual acuity was restored to 20 to 20, and complaints of visual field effects disappeared, and we can see the decrease of the patient weight. On the follow-up of our patient, the fundus of both eyes of the patient after 6 months of taking acetazolamide, the amount of edema was normal. And also we can see the decreased thickness of RNFL in both eyes. So if papilledema is clinically suspected, blood pressure should be measured, followed by magnetic resonance imaging of the brain. Look for cause of increased ECP and rule out on non-idiopathic causes. Lumbar puncture should be performed, measurement of opening pressure, assessment of the composition of the cerebrospinal fluid should be done. So the most common prevalence of papilledema is young patients, especially the age less than 50 years old, and idiopathic intracranial hypertension. Idiopathic intracranial hypertension is thought to be most common among obese women of childbearing age 20 to 44 years old. So management goals should be directed at the main cause of the increased intracranial pressure, treating underlying cause, saving vision, symptomatic relief. And in our patient, the cause of the idiopathic intracranial hypertension was not identified. Just the diagnosis of idiopathic papilledema was made. So papilledema is a significant clinical sign that warrants immediate attention. This case report emphasized the importance of a thorough evaluation to determine the underlying cause, establish an appropriate management plan, and prevent long-term complications. Early diagnosis, multidisciplinary collaboration, regular ophthalmologic follow-ups are essential for achieving optimal outcomes in patients with papilledema. So this is my sources. Thank you for listening to me.
Dr. Ayan, thank you for the nice case report presentation.
Yes, thank you. So I'm sorry for technical problems.
It's
Back
okay.
from the beginning.
We are happy that you are with us.
I'm also happy.
I have just a few comments and maybe questions. I didn't see ultrasound of your case. Did you perform ultrasound in a case with papilledema?
Unfortunately, I didn't perform. No.
And the second thing, I didn't see visual field test.
Yeah, the visual field was not controlled beyond me. Unfortunately, we lost the results. I wanted to put in this presentation, but there was a problem in the machine, which is in our clinic. So I couldn't put them, but we done visual field.
And the third thing that I was wondering about is you didn't mention the differential diagnosis for papilledema. I think in each case of papilledema, we have to look carefully for think about wide differential diagnosis. Can you tell us a few?
So about differential diagnosis, I thought it's like how to say that easier, and I didn't mention it. I can mention with you that optic nerve edema, it's first caused. You mean like when we check the patient, yeah?
Yeah, if you have a patient with papilledema, with optic disc edema,
Yeah.
as you presented the case, which is real optic disc edema, what other options rather than PTC, benign pseudotumor cerebri, or benign?
The abscess
increased.
on the brain, it can be caused. It can be caused after some trauma. The tumors can be caused. Also the taking the drugs, for example, tetracycline or vitamin A or other steroids. This also can be caused. The obesity is main factor. And the young patients, especially ladies.
When I was resident, one doctor taught me to every time to think about differential diagnosis, just to mention it, to try to divide it into groups, like main causes, inflammatory, space occupying, infiltrative, into groups. This will help. And the last thing is, do you know other modality treatment of increased intracranial pressure in such cases, rather than the medical treatment?
Okay, if the patient is not tolerated to medications and all the plans, for example, which I show you, this kind of plan which I did to our patients, it's the second option is surgery. The surgery can be a neurosurgical shunt, yes, optic nerve sheath decompression surgery, maybe. We can done like.
Okay, thank you, Dr. Ayan. Thank you, Dr. Ayan.
Thank you.
Thank you.
Okay, thank you all panelists for this precious time. Thank you, our presenter, for this nice presentations. We can see you next week for the last session of the iTeach second competition, inshallah.
Inshallah. Thank you,
Anyone, any panelist have any comment?
The last one, Nuran Bal'Arab is not available.
And Nuran, yes, is loss of connection because she has flight and she apologized for this.
No problem. Yeah, inshallah. نراكم على خير. See you inshallah.
Thank you.
شكرا دكتور علي. شكرا
السلام
بروفيسورة سوزان.
شكرا جزيلا. شكرا
يعطيكم
جزيلا.
العافية.
حياتي نلتقيكم الجمعة القادمة إن شاء الله. مع السلامة.
مع السلامة.